All right, we'll get started. It's just a few minutes after 7 here, so we will get started. But I just wanted to thank everybody for attending tonight, our town hall on opioids. So I know there's a lot going on this evening with it being a voting night, but thank you for coming out. So my name is Ben Rasmussen. I'm with Community and Family Resources. I'm a prevention specialist with them. And our task force group that is led by multiple agencies throughout a few counties here in central Iowa, the North Central Iowa Task Force, has come together to put on this opioid town hall. And so tonight you all will have the opportunity to hear some very unique and different perspectives and information from the panelists here, but then you will also, as the audience, have an opportunity to ask some questions and direct those questions to our panelists. We would ask, so if you do not have note cards, please raise your hand. We will get some note cards passed out to you, and then just when you're ready to pass in your note card for your question, just raise your hand, and Todd and Wayne will be coming around and they will grab those note cards and we'll get them read. But we would ask, since our topic tonight is on opioids, we try to keep our focus on that subject so that we can really focus our efforts there. So just to get started tonight, we do have a brief video for you all to watch. It's going to be roughly about 5 minutes, and then we'll go into introductions and we'll get to a presentation with Peter, and we'll get our evening started. So we'll get started with our video.
Just to give you a brief background on the video. Public television did a show about 3 years ago, and last year they came back and asked what's new, and not much had changed. And this year we're hoping that the next edition of the show on Market to Market by public television is about how we've taken what we knew 2 and 3 years ago and begun that community activism aspect that you represent here today, where we're actually carving solutions out in the communities to help diminish the risk to Iowans. So enjoy the show.
What do you guys got? Possible overdose. There's some stuff sitting on the table there. Can you wake up for me?
I think the best definition of addiction that I've ever heard is an irresistible urge to perform an irrational act. An irresistible urge to perform an irrational act.
Over 2 decades ago, painkillers derived from synthetic morphine were seen as a miracle drug for patients coping with chronic pain. Since then, numerous forms of synthesized narcotics have made their way into doctors' offices and pharmacies. According to the Centers for Disease Control, as the number of opioids increased, so did addiction rates. The Trump administration has declared the problem a public health emergency.
They hit people with suits, with dresses, indiscriminate. But because the perception of risk were down, it was like inviting the drug dealer to your child's birthday party. You know, they were just handing them out because it was supposed to be thought of as a good thing.
In 2015, the CDC reported over 33,000 deaths nationwide related to opioid overdose. Over the past 2 years, that number has more than doubled.
It's hard not to look at it as a war. We've gone from 64,000 people dying in 2016 to 72,000 in 2017. That's over a 10% increase in fatalities when we know what the problem is, when we have a grasp of this problem of opioids. So there has to be some deeper issue systemically.
Wake up for me, dear.
Those developing the strategies to fight opioid misuse are fighting a war on 2 fronts. One is availability. Officials with the Iowa Governor's Office of Drug Control Policy are concerned medicines like Percocet, Oxycontin, and other fentanyls have a safer persona than illicit drugs. Komendowski believes that safer persona creates a climate for addiction. The other front is the amount. Federal government officials contend, with a perception of low risk, opioids have been prescribed in ample amounts, with little concern for misuse. Making physicians aware of how many pills are being written into prescriptions is one way opioid misuse is being confronted.
Previously, you'd see a prescription come in maybe for 60 tablets. Now we're seeing more prescriptions written for 30.
As a licensed pharmacist,
Bring that with you, though.
And legislator in the Iowa House of Representatives. John Forbes uses his unique position to help craft legislation aimed at helping curb opioid misuse in rural Iowa. But Forbes knows he and his colleagues on the other side of the pharmacy counter are on the front lines of fighting the epidemic.
Pharmacists just need to be vigilant whenever they have a prescription presented to them that they have questions about.
A tool pharmacists use when a suspicious prescription comes to their attention is the Prescription Drug Monitoring Program, established in the 1930s to track Schedule II narcotics. The program has evolved to an electronic database stretching coast to coast.
We check that database on new prescriptions, especially patients that are new to our pharmacy, to make sure they're not doctor shopping or going to multiple pharmacies to try to obtain controlled substances.
Last year, the Drug Enforcement Administration stepped in to help slow the opioid epidemic by allowing pharmacies to partially fill prescriptions.
A program like this helps keep larger quantities of opioids out of the system, so there's less chance for diversion.
Let's go ahead and give that Narcan. Narcan. Verified.
A life-saving drug helping addicts who have overdosed is a medication called naloxone or Narcan. This product can bring someone out of an overdose in minutes, but it also has a high price tag.
Narcan going in at $15.07.
One dose can cost up to $100, which can strain small-town budgets. And it comes with one important caveat.
It's an opportunity to treat and care for somebody, to intervene. It's not a cure. And that's the biggest misconception we see with naloxone.
One place that treatment and care can be found stretches over a 7-county area in north-central Iowa. Prairie Ridge Integrated Behavioral Health Care in Mason City is a treatment center exploring new ways to help people cope with addiction, combining mental and physical health services with recovery treatment. The center uses state-of-the-art technology and strong doses of compassion to help shrink misuse disorders in rural Iowa.
That's the thing we have to keep working on, is to make substance use and mental health treatment part of our healthcare system, not something that's viewed by the public as a weakness or a moral failing. It's a biochemical brain disease, and it's really time that we focus on that as opposed to an act of willpower or lack thereof.
And when the consequences hit American culture anywhere, low population, rural areas where the density is low, they have the least amount of health care, the least amount of counseling, the least amount of resources for public safety. They're at risk for much longer than where we can apply all the big money and resources.
All right, she's waking up a little bit. What's your name?
Tiffany.
Officials in the Hawkeye State see a long fight ahead that will require a balance between limited funding and scarce resources. They also believe to win the war will demand an increased respect for the medicines being prescribed. For Market to Market, I'm John Torpy.
Okay, and so that was just a little video to kind of get us started. Hopefully that spurs some questions that you guys may have, but we will at this time introduce our panel. So we'll start from right to left. We have Peter Komendowski, Sergeant Don McLaren, Dentist Dr. Sean O'Neill, Chief Deputy Rod Strait from the Webster County Sheriff's Department, Mandy Krause Kelly, Dr. John Daniel Jr., Denise Ryder, and Carrie Cook. So at this time, we'll also give them the opportunity to just kind of share with you why they are being here today, or why they are here today. So we'll start with Carrie, if you want to just go ahead and turn on your mic and share why you're here today.
My name is, oh, that's loud. Hello. My name is Carrie Cook, and I'm with Community and Family Resources. I have been with Community and Family Resources initially since 2012. I work as a substance abuse counselor there, an evaluator, and I most recently moved back from Phoenix, Arizona, where I worked for a couple of years there under a MAT clinic, which is Medicated Assisted Treatment Clinic. in Phoenix, Arizona. So, and I'm just recently back here in Iowa, back at CFR.
Thank you. Okay, Denise.
Denise Ryder, and I lost my son to an accidental overdose. So I'm just going to give you a quick timeline of what happened. Fall of 2008, during football, my son Dalton was tackled and dropped on his head and neck. Following this incident, he had chronic migraines. He was prescribed hydrocodone along with medication to prevent migraines. Spring of 2009, Dalton had a knee injury from a bicycle accident and was again prescribed hydrocodone. Winter of 2009, Dalton, the clown that he is, felt the need to try and impress some girls in gym class. He'd done 2 walking handstands across the gym and made a third attempt. The third attempt resulted in a trip to the emergency room. He'd injured his shoulder. This time it was an AC separation. Again, he was prescribed hydrocodone. Spring of 2013, Dalton was able to pursue his dream of racing a sprint car in Knoxville. He raced the 305 class and was showing a lot of potential for being 16 years old. On July 13, 2013, he was involved in a bad pileup and sustained injuries to his low back during a sprint car race. In the coming weeks and months, he requested to take hydrocodone. I would give him one with supervision of those leftover hydrocodones from other incidents. Summer of 2015, he contacted his sister to see if she had any pain meds from her C-section. She raised a red flag with his father and I, letting us know he was looking for pain meds. I had conversations with him about this. He swore he only needed one because he was digging trenches, laying tile. Fast forward to January 2016. Dalton had moved to Arizona. He called asking for advice how to deal with constipation. I again questioned him about the use of hydrocodone. He swore he wasn't taking any. On March 5th, 2016, I got the call that forever changed the course for our family. Dalton, my 19-year-old son, was gone, and there was no apparent reason, so an autopsy had to be performed. It took us a full week to get my son's body home to Iowa from Arizona. It took another 3 months to get his cause of death, accidental overdose. Those words shook my world. The accidental overdose was hydrocodone cut with fentanyl. They said about the equivalence of 2 salt granules took my son's life. We can only assume Dalton did not have a doctor in Arizona and asked a friend or a coworker for hydrocodone. My son was smart, talented, hardworking. His life was cut short because of this horrible epidemic. If you do not personally pick up a medication from a pharmacy, please do not assume it's safe. Had I known what I know now, I would have asked for alternative methods to control his pain, and if hydrocodone was needed, I would have disposed of all the extra rather than hanging on to those.
Thank you, Denise. John?
John Daniel, pharmacist at Daniel Pharmacy. I received my PharmD or Doctor of Pharmacy degree from the University of Iowa in 1999, and basically worked at Daniel Pharmacy for 18 years as a pharmacist. Oftentimes we see a lot of prescriptions for different type of pain medications, and what we see now is a lot of the insurance plans are having a limit of maybe 7 days on their first fill. And possibly need a prior authorization to determine from the prescriber if additional is needed. And also now that the state of Iowa Board of Pharmacy has allowed for partial fills of controls within 30 days, if we have a prescription for a larger amount for possible surgery or anything like that, we're able to fill less than the full prescription, sufficient amount for whatever their needs are, and we can do the remaining within that 30 days. Whereas before, either fill it all, or if you do a partial, need a new prescription for the remaining.
All right. Thanks, John. Mandy?
My name is Mandy Krause-Kelly, and I'm the Executive Director at the YWCA here in Fort Dodge. At the YWCA, we treat women with substance use disorder, and I'm here to talk about, I guess, our experience on the side of addiction treatment. About 10% of the women that we see come in with some kind of addiction to opioids, and so we deal a lot with everyone here at the table in battling that on the treatment side.
Thank you. Chief Deputy Straight.
My name is Rod Straight. I'm Chief Deputy for the Webster County Sheriff's Department. I am entering my 32nd year of law enforcement. All of that has been here in our community. I started off with the Fort Dodge Police Department and switched over to the Webster County Sheriff's Department in '96. The law enforcement role of with the Sheriff's Department is not only law enforcement but housing of inmates. We see a lot of drug addiction come into our jail. Also, we have to work with medical professionals and pharmacies to get prescriptions for our inmates, and so we see them trying to do a lot of, as they say, doctor shopping. We control those efforts. We also are involved in the drug take-back program. Our most recent was in the last week of October, working in conjunction with Daniel Pharmacy. And with just that last one, it was over 30 pounds, I think almost 35 pounds of opioids that was sent back to the DEA. Currently, we don't have to send them back. We just destroy them, get them burned through Gunderson's help us out with that. And so our law enforcement role with the Sheriff's Department, working with these inmates, they come in with a lot of drug addiction problems, and we take them to medical professionals. They're working very well with us to help with what they get. It's kind of unusual to be there, and they know exactly what drugs to ask for. They even specify the milligrams that they want, and they usually try to exceed the doctor's what they're even willing to give them. So it's just a different role of law enforcement that most people don't really see when you're housing them. So, but my opinion is our law enforcement role is very important in combating this, but I think the real answer is lies with our medical professionals and our pharmacies and what they're doing. Most people want to point a finger of blame, but I think our answer lies with them.
Thank you. Dr. O'Neill.
Sean O'Neill, I'm a dentist here in Fort Dodge. Have been in Fort Dodge for going on my third year. Dentistry or dentists have been one of the major prescribers of opioids in the past. Over recent years, that's starting to change pretty dramatically. But I'm also a major user of the prescription monitor program that has been put in place. And with some of the e-prescribe regulations that are coming in, we have to click that has been searched before we're allowed to e-prescribe. And I would say 1 out of every 5 or 6 patients coming in pain, wanting pain meds, when you check it, it would be their 4th or 5th time in the last month or 2 trying to get pain meds from a prescriber.
Thank you. Sergeant McLaren.
Don McLaren, Fort Dodge Police Department. Been on the police department for about 12 years now. I'm the sergeant of our investigations unit of 6 investigators. Part of our role is obviously investigating narcotic cases, including prescriptions and opioids and that type of thing. So just here to share that aspect of all of it.
Thank you. And Peter?
Thanks for everybody being here. The panel itself represents a good cross-section of how many people we have working in public safety and health and community resources to try and help deal with this terrible epidemic. And I know that every one of you has a passion for some aspect of it, so I'm going to share some information about the epidemic, the nature of the epidemic, how we're faring in Iowa, and hopefully generate some ideas for questions from you, especially with the idea that you each individually can have a lot to do with the outcomes in our community and what we can do to help stem this epidemic in Iowa. You've seen the video, which is important because we know we have strong engagement around the state. I'm very blessed to work with an organization that's Iowa's oldest coalition of prevention organizations. And we have a lot of really smart and successful people that have one goal in mind, and that's to keep Iowa communities safe for children. And it's getting harder and harder to do. And when we take a look at some of the statistics just for the opioid epidemic, not considering every other risk factor that's out there, has huge economic impact on people's lives. We believe that today there's about 10.5 million people addicted to opioids or some logical progression from opioid addiction like heroin addiction, and I call it a logical projection. That's a very sick way to look at it. It's not logical, but it happens. We have a huge amount of fatalities in this country. And to put into context how major this epidemic is, if we take a look at the 65, which is now like 74,000 a year, I mean, the clock keeps ticking. Even good news about deaths from the opioid epidemic is that the rate of fatality is going down. But that only means there's more people dying every year. They're just not, the number's not increasing as fast as before. That's how difficult it's been to grasp. Because when we take a look at 70,000 people dying a year last year, that's more than all the servicemen we lost in the Vietnam conflict. That's a terrible thing. And that, it doesn't take into account the fact that we lost a lot of servicemen after the Vietnam conflict to suicide, drug overdoses, and things like that. But we're looking at the scope of numbers here. We've had more people die from this opioid epidemic than died fighting World War II. And we're getting to the point now where we're going to exceed the total amount of deaths of the Civil War. And the only reason that fatality rate was so high is because it was one country fighting against each other. This is a lot of people dying. 74,000 people leaves children behind, caregivers behind, aunts, uncles, grandparents. A huge amount of orphans. So the scope of this should be undeniably huge. I mean, this is the biggest disaster on any scope that this country has faced. It's killing more Americans than World War II. This is a big deal. And so when we start looking at the nature of this epidemic and how it moves this country, we start seeing that it's sort of, wow, really, you can see the focus on a national map. There's a lot more prescriptions in areas where there's a higher and more dense population. That's true. That gives Iowa sort of an advantage. Now, 18 years ago, Dale Woolery from Office of Drug Control Policy and I did a town hall meeting in Dubuque. There was an alarm sounded about the opioid epidemic. Over the next 5 years, we screamed and shouted about the opioid epidemic, and very little happened. Then something profound happened that woke America up, and that was we started counting dead bodies. It was terrible. It's a shame that's what it takes, but that's where we are today. We have a huge fatality count. But we can go back and look at early CDC reports. Now, they started really tracking opioid deaths in 2008 or 9, but they knew in this report, you don't have to read it, from 2000 to 2009, they saw a spike of teenage deaths from drug overdoses related to opioid pain medications. So this is neither new or unknown. It's been going on for almost 20 years now. But it's time for us to do something. Let's talk about first how an epidemic works, because there's something in here, when we talk about epidemics, we always think they're a bad thing, but solutions or good ideas can spread the same way as bad ideas. So the press is always about the bad things that happen. But we can use the same model of epidemiology to help fight the opioid epidemic as is defeating us. And we do this. I talk to doctors at grand rounds, and we talk about this. We can't just look at it and say fatalistic, oh, epidemic, we're dead. No, I want to spread an epidemic of good ideas, where coalitions do good work, where people in the community start doing the things they can do to keep their community healthy and safe by the same methodologies, because epidemics work like this. Initially, there's a phase called establishment, then it grows, and then you start recognizing there's a problem, you start slowing things down, but there's always this residual benefit. Well, we're still growing. So if you look at this graph, we may not have peaked yet for the number of fatalities that are coming from this epidemic curve, but don't let that scare us. We may be saving more today with everything we're doing. It'd be amazing if we didn't do all the things that we do today to help stop the opioid epidemic, where this graph might peak. Might be a lot scarier than the numbers we have. So now let's take a look at how we dissect an epidemic. In those phases, we have a susceptibility phase, where people get exposed to these drugs, whether it's innocently by prescription or by drug experimentation or whatever. Now, after that process, there's an infectious phase of an epidemic. In this case, it would be the addictive phase. Now, when you start to fight the epidemic, You reduce the amount of infection, which is since reducing the amount of opioids that are being trafficked and made available to people. Because there's a direct correlation with how many opioids are out there and how many people die from overdoses. You then have people in recovery and treatment, which is a very difficult, it's something hopefully we'll talk about because it's very expensive and very hard. So we have not only the expenses and the evolution of recovery and treatment, we have the continuing effects of the epidemic existing, and then we have fatalities, people that will die from overdoses. This is sort of how an epidemic works. It comes, grabs hold, a bunch of stuff happens, whoo, let's start slowing things down, but in the meantime, enough people have the contagion, whatever it may be, there's some fatalities, we figure out how to cure it, and hopefully it goes away. Well, what's the problem with opioids? It's not one point source. You know, malaria might have come from one mosquito somewhere in South America. A bird flu virus may have come from Thailand. You can propagate an opioid epidemic in every community, in every pharmacy, from every doctor's office, in every drug deal. There's no limit. Fentanyl has showed us that even the internet and postal service can be used to propagate an epidemic. So when we have these continual potentials for propagation, the propagation points come closer and closer to home. We can't blame New York. We can't blame the West Coast. We have to look at our own communities and see how are these things working. Are we managing this risk and threat effectively? And again, that's part of the purpose of these town halls and local coalitions, because we live in the culture that's now a network civilization. This is a lot of picture, and I do an entire hour on this topic alone. The fact of the matter is there's been primary breaking of connections in this culture, where we've been able to grow and get better connections, like know what's going on in Biafra or Africa or Europe or whatever else. Sometimes we're not seeing the things going on close to home. Things are sort of breaking down. The amount of time people spend talking to each other, the amount of time people spend with children. Every one of those voids, when we're not looking at our neighbors or the people next to us or the people that we should be caring about, is an opportunity for things like an addiction or substances that are prone to addictive use or abuse can get into families, into communities, and start doing damage. So there's a sort of vigilance there that comes from caring and compassion that we want to talk about, because when we look at the factors that feed substance abuse, now take a look at this. On one side, there are many, many people tragically become addicted to opioids because they're prescribed opioids, and we believe they were a good thing. And there's no doctor happy that they were deceived by a pharmaceutical industry. This was a bad thing, but it's here, we have to deal with it, and doctors and pharmacists are now also on the front line of helping solve and cure this problem. But we also have people that naturally search a high, whether it's alcohol, whether it's marijuana, whether it's some other drug, and we start looking at what are some of the, in opioids we say one of the common reasons people encountered addiction was pain. But opioids moving on to heroin start now sharing sort of a community with other kinds of drug use that we have to be careful about. Because the precursors to the kind of response that your brain gets to using a drug that's addictive are not always just pain. The disease model will tell you that we have a susceptibility, whether it's to malaria or the flu or a cold, and not all of us cope well with that. And the model that leads to drug addiction also could lead to things like sexting, human trafficking. There's a lot of different outcomes. God bless that with opioid addiction we have a choice to be able to identify what that problem is, a lot easier than a lot of others, but there's a close relationship between them. So now how do we take that knowledge and look at evolving a process to improve outcomes and reduce the incidence of these high-risk behaviors and things that we don't like happening? And that's called, and it was mentioned by Ben, perception of risk. If we know children have a perception of risk, or adults have a perception of risk, they are less likely to engage in that behavior. One of the reasons opioids got great purchase is because the people that were deceived were doctors. And we trust doctors, and justifiably so. As a social experiment, this mistake may save millions and millions of lives in the future. Unfortunately, they're costing us some now. Well, perception of risk is an interesting thing to manage, because that is something that doesn't just come from the media or the news, but it happens in every home where there's parenting. It happens in every situation where there's grandparenting. And it's interesting. We know that if we understand risk, we do a great job of reducing that problem, of mitigating that problem. So we're in this phase now of this epidemic where we're learning that the risks are big, that there are going to be hard choices made, that we have to know how to deal with addicts, and we have to know how to deal with the negative use symptoms that we have from not just opioids, but all the other things that sort of compromise our ability to live healthy. So we look at what the whole matrix is of risks. Now today, if we look at primary substance abuse of people entering treatment, we don't even see opioids on that list right now. That's how quickly these things are changing. When we even look at youth drugs of choice, we've seen from, I forgot what year this is, 2012 to 2016, a huge increase in marijuana use. And we're starting to see that perception of risk change. Now, I'm not here to talk about marijuana too much, as a matter of fact, very little, but I'm here talking about perception of risks and how our children are affected, because right now they're growing up in a climate where they're maybe not even learning what they should be about the opioid epidemic and how those risks affect them. Because when we look at Iowa Youth Survey stats, and we look at things like, the first one is social pressure to use substances, I will tell you that, you see the blue number, that's the 6th graders, I think the red number is 8th graders, and the green number is 11th graders. If you look at this graph the right way, you look at the first chart where you see the blue number, and by the time you get to that green chart, that's those same kids. They go from blue to green in that course of time. Now, we are doing well with children in each successive grade, but between 6th and 11th grade, we're failing. There's a 480% increase in this stat. And if we look at more slides, from youth access to positive social norms and student norms, this is a belief that it's okay to do these various drugs. So here's a tragedy in the making. The youngest, most vulnerable people in our culture that we're probably going to be able to protect from the opioid epidemic are not immune to any other form of epidemic that may follow. So what the important point there is the lessons we have to learn from the opioid epidemic. Not only do we have to use them today to help our communities and people heal and protect themselves from these risks, we have to remember that these lessons must be shared with our children. Because when we look at an epidemic like this, it's like a forest fire. If the fires are burning in California, you don't sit and say, what's the budget? How much can we afford? You put every resource you have into putting those fires out. And then you count the dollars later and you solve the problem. But we've learned that you also have to have some prevention. In the case of forest fires, it's like Smokey the Bear. So even though we're here to focus on this opioid epidemic and the way it's manifesting itself in our community, we cannot forget that the importance of the prevention work that our community coalitions, that our parents, our grandparents, and our community leaders all do with youth and families to make sure that this is not repeated with some other drug or in some other way. We must learn from the fatalities we have here. And this is my last real talk about marijuana. It's the fact that you will hear people tell you that marijuana may help deal with the opioid crisis. There is no good evidence to that effect. I'll debate anybody. The only people telling you there are people trying to sell you marijuana. So the good science is that it's not going to help us with the opioid epidemic. Don't even think about it. As a matter of fact, if we look at CDC stats, we can see there are strong correlations with all these drugs of abuse with eventually ending up using heroin. And all these slides will be available from a prevention group. I'll give them all this information. A lot of this data is available online. We work with Mayo Clinic, with Iowa State, with Brigham Young, with researchers in Singapore, all over the world. So I bring a lot of stuff to bear. I don't give you a lot of information about where I got the data, but I assure you we have it if you'd like to see it. Yeah. Now let's go back to opioids in children. And we heard a story about what happened with her son. This is legitimate opioid use. Take a look at that number. If you ever have a child going in for surgery or something, if listening to your story is not enough, we know you wouldn't do anything that gave you a 33% risk of getting into this kind of a problem. So even legitimate opioid use, because of injury or surgery at that age, there have been studies that have shown in treatment, and I'm not a doctor, but we've read these, that treatment in young children, and I think this study was kids like 10 years and younger, had a better response to aspirin than did opioid pain medications. Now that we've learned that opioids were a bad idea, they're not the miracle drug that everybody believed they were, we're starting to look at the things that worked before, and some of them actually work better than opioids without the addictive problem. And here's where the addictive problem manifests itself. Youth. Every form of addiction that's out there, if you're going to be vigilant in your communities, has a more positive and detrimental effect on children's development. They are more susceptible to addiction when they're kids. And that should sound logical. Now, there's also a good side. When we identify risks, and every one of these risk factors were the domain of a prevention organization like the one that's running this meeting, when we know them and we work with communities and we get the word out to kids, we do a great job. But the world is a cruel place. It can sometimes perpetrate problems that are faster than we can respond to them. So I can go on a long way with data. I want to get to the point where we can answer your questions. The next charts I'm going to show you are all available on the Governor's Office of Drug Control Policy's website. It's called ODCP. Again, I'm sure your coalition can hook you up there. They have tremendous research on this. There are a lot of quote-unquote flavors of controlled substances. We pretty much know what's being prescribed. We know what the targets are, and we know we're trying to get off the market. At the same time, we're seeing a lot of illegal synthetic opioids and fentanyls, things that are so deadly that the size of a grain of sand can kill you. You know, we need naloxone. I refer to it in that tape as it's not a cure. It's a way to initiate a process of healing. But when our public safety officers, police officers, people in EMTs, medical practitioners, if they can come into a contact of a grain of sand that can kill them, we need naloxone to keep them alive. In that instance, it does save a life. Because this is not somebody who's suffering from a disease of substance abuse. This is somebody now can make an accidental contact with something that's extremely deadly. So we've seen opioid treatment admissions go up, ER visits go up. We're starting to see drug-impaired traffic fatalities on the rise. Opioid OD drugs. I mean, we're doing really good on a lot of drugs, but opioids are still being a booger. Nationally, they're still going up. I'm not saying all these things to depress you. They're depressing numbers. But I'm talking about them because they should be teachable moments. Lesson number one, if a doctor today prescribes opioids, number one, you should make sure they're on the PMP. There's no reason you shouldn't. That's a physician's monitoring program. Number two, you need to be aware that the rate of addiction for use of an opioid product after 5 days begins to rise dramatically. So this is a drug that should only be used for a short period of time. Remember I talked about perception of risk? Sometimes there's also perception of benefit. We don't need to be afraid of opioids if we use them properly. Now, they're not going to help me with my chronic pain for 6 months, 8 months, or 10 months. I know this now. That's not what they might have told me 15 years ago. But I know this now. But I also know that if I have anybody, and I run into this all the time from friends, if you're having a surgery, don't take a longer prescription than 5 days. If this isn't enough, some of these stats will show you that the risk isn't worth it. I'll tell you, pain of any sort is better than substance abuse disorders. Now, and here's something that's fascinating, and this is why this should empower you. We talk about addiction as a disease, and it is. But one of the primary aspects of this disease, it doesn't take you off the hook for choice. The disease influences your choices. It will make you lie to people, as you knew. A person suffering from substance abuse disorder, and I still like to use the word addiction, but I'm not supposed to anymore. Unless I'm talking to addicts that don't like the fact I call it substance use disorder, because they're happy to have fought or be fighting addiction. But the fact is that it changes your brain. So then what is a disease? One of the symptoms is the fact that the choices that addict begins to make are bad. So there are still choices in the equation. And here's the problem. Once that person is your friend, in your family, and that change happens, you're no longer their friend. They may be your son or daughter, but they will not, it's not that same circle of influence. And how many people that have had children suffer with substance abuse disorders have recognized the fact that they can't have trouble connecting with them? They have trouble understanding what they're going through. And how many have said, what would I have done differently? Though you may not have been able to change a thing. That's the harsh reality, that we can try and do a lot of things differently, but sometimes you can't change everything. So the people that you know that are close to you, that you care and feel for, if they suffer from the disease of addiction, they're not looking at you the same way anymore. And that shouldn't be reason you abandon them. But it should be a realization that this is a very, very difficult place to be, and anything we can do in prevention in advance of it's important. And so that's the great thing that we also like to talk about, is the fact that we have many, many more chances now to monitor the traffic in Iowa. So we got this huge epidemic going on, and we're trying to minimize the risks to Iowans. Trying to not, because it's still moving through the country and it's still growing, but we're doing a pretty good job in Iowa, kind of slow it down. So we're also identifying the risk. We have more naloxone in the hands of people than ever before, and we're looking at low price options to get more of it out there. It's not even the most stable thing. So, you know, it's like asking a police officer or deputy to actually have more. You have to worry about the temperature and how you store it. It's just adding another thing they have to worry about while they try and do their job. And then we have these wonderful take-back initiatives, 35 pounds here, 25 pounds. There should not be an opioid in a medicine cabinet that's not an active prescription anywhere in this country. You want to know what's sad? The sad thing is finding out that the person that killed a grandchild was a grandmother or a grandparent because they had unused opioids in their medicine cabinet. That's a sad story. It never needs to happen. These drug take-backs are serious. And they don't have to just be one day a year or twice a year. If you know somebody that has these drugs, get rid of them. Where's your take-back site locally?
Our drugstores and in our sheriff's office.
There's no reason they should be around. They've led to more problems with addiction that you'll ever know. And there's perimeter ones, I believe, in every county in the state now. We're also seeing an increase in physicians enrolling in the monitoring program. Now, if I understand this correctly, it's not simple to do monitoring, is it? It's a lot of paperwork. It takes time for the monitoring program to address it.
Actually, it's pretty simple now that it's all online.
Okay.
The hardest part is trying to remember your username and password.
Well, that's a good thing, because in the first few years, the number of people that utilized it was very small. And that number's been growing. I don't have the new one. But it's also deterred doctor shopping. It's, you know, we've seen a reduction in Iowa of the number of opioids being prescribed. And there's some statewide priorities on increasing the prescriber use of the prescription monitoring program, reducing the amount of opioids being prescribed, providing more effective interventions for people that need help or recognize there's problems in their family or friends. And then we're trying to build a climate where we can provide medically assisted treatment to more and more people. But here's something to recognize. Right now, at least 10.5 million people have a problem with opioid-based dependency. If we could take every one of those people and put them in a medically assisted treatment program, which could take a year, 2 years, it's not fast. The costs at this point are prohibitive. So, you know, we don't like to leave casualties behind, and I don't like the metaphor of war, but it's realistic here. The casualties are too high. When you're losing 70,000 Americans a year, how many orphans, how many people are left behind? It's time to look at every aspect of this. So never discount the fact that a little bit of unused prescription in your medicine cabinet might be a risk. Because if everybody in this county went into those medicine cabinets and took all those things back to the drug take-back, you'd save somebody's life. That's the numbers just bear it out. There's no reason to allow it to happen. So this is the key here, and I wanted to go to questions, because the fact is that the epidemic was not anybody's fault. There were people that did really wrong things that were able to twist the outcome so that today we have an opiate epidemic that we wish we could have avoided, because in retrospect, like most things, it is avoidable. But when we fight a war, and we're not afraid to admit that there's some serious, serious consequences here if we fail, as Americans, as Iowans, as community members here, we don't give up. We don't let somebody else solve our problems. We go to work, because the solution does start right now in places like this. It starts with people like you. You know, we've all been after the fact. We show up when the problem's there. We're trying like all get out to do every bit of prevention work, get every bit of awareness about these resources. and get into even schools and kids to know these risks, because to think that we can just blindly protect it from them without engaging them in the process of learning that needs to come with the price that's been paid is not good. So every one of you has an immense amount of power to change this outcome for the state, and I encourage you to ask whatever questions you might have, just so you can go home with a little bit more of an edge to try and help somebody or be somebody. And then next time when you see a town hall, get your friends to come or share some of the wonderful materials they have. Thank you.
All right, thank you, Peter. So at this time, we do have a couple questions to get us started, but we just want to remind you, you do have, if you need a note card or you need additional note cards to ask questions, we'll have a couple people filtering through the audience. So if you have a question, just raise your card up and we'll collect that and we'll get that up to the podium to be asked. And then if you do have a question that is directed at one of the panelists in particular, if you could please add that on there just so it's easier for me, that would be very much appreciated. But just to start, we do have a question here. So this is for whoever or as much of you that would like to answer. What do you see as the problems related to prescription drug use in our community? And anyone who wants to tackle that or begin can certainly start with that.
I'll go ahead and begin, just to break the ice, I guess. It usually starts in the home, with the prescription. Is detrimental to the family. The substance abuse begins, and then it can easily roll into other substance. Once they no longer can get a prescription, and they've burnt their bridges with the family, collecting, the medications from other family members. So, and then they find themselves in contact with law enforcement, and it just goes downhill. It's just a problem that just continues to snowball.
Thank you. Anybody else like to add to that? Okay, so we do have a question from the audience. Why can't we stop the, let's see here. Okay, we'll continue on with that while we get this question.
Well, you figure that out. I'll add something to the previous one. When they ask about why we have a problem with prescription drugs, I will tell you that if you talk to people in the drug business, not illegal drug dealers, but the people selling drugs, alcohol, tobacco, all of it, they will say that we have a society that wants everything fast. They'd rather take a pill than do the hard work. And you know what? I think I'm the same way. I mean, we're inherently lazy. We like to buy our way out of problems rather than have to work hard to solve them. So, yeah, it starts in the home, but it may start deeper in the home and the framework of family and parenting and community than we care to want to admit. That sometimes we're looking for easy solutions. Because I'll tell you, with pain and what propagated a lot of the hurt to elderly people in America was the fact that promise of pain relief, when in fact there's a part of aging and pain that's never going to go away. It's just part of life. And Grandpa and great-grandpa lived with pains that we today think we should be able to take a pill to get rid of. And to them, they just lived with it. So there's something to be said, too, for the fact that our attitudes have changed in a way that maybe isn't healthy when it comes to prescription drugs.
Thank you, Peter. All right, so I got clarification on the question. Why can't we stop the manufacturing of opioids and or the large amount of painkillers?
I'll start it, but there's a lot of people that could talk about it. Fact is if when you have 10.5 million addicts and they're getting opioids, where are they going to go if we stop them tomorrow? I was with a national meeting of model state drug law people, and it was their goal and their mission to stop all the illegal access to opioids. But I said, how can you be compassionate with the addicts? And that's obviously the answer is medically assisted treatment. Not only do we not know how to stop it, because for a lot of people they're necessary. And I mean, there's still valid uses for opioid-based pain medication. It's just there's strong limitations on where it's good. But at this point, we're beyond being able to stop it tomorrow. Even if we could stop it, could you imagine 10 million people in withdrawal? They can't get their fix, they'll be buying heroin. They'll be on the street doing much worse things. I'm exaggerating a little bit, but that's not far from the truth. So we're in a position where we have to slowly fix the problem. There is not a quick fix available.
Anybody else like to add on or have anything else to say?
I can try add to it. I mean, like he said, there is valid uses, medical uses. If anything, there might be limitations on how much could be manufactured instead of stopping altogether. I know for us, in most pharmacies, we have to, at least yearly, submit how many different opioids or controlled drugs that we fill within a certain time period, which limits how much we're able to purchase or have on hand. So I'm sure that a lot of the manufacturers probably have some sort of limits on what and how much they can make.
Okay, thank you. All right, so we do have a few more questions here. So do you need to treat the mental the mental health along with the addiction?
I can speak to that. Absolutely. Treating any addiction, you have to look at the whole person. It's not just a substance use disorder. There is often factors that factor into that as well, whether it be mental health, the ACEs, the trauma, the things that they've went through, they need to deal with, the things that they may need. I mean, our women that we see are often homeless. They don't have jobs. They have children to take care of. They're in poverty already. And so we have to treat the whole person and not just focus on simply the drug use. And so, and that goes with any type of addiction, not just drugs. It could be anything. And so I think it's important that any type of treatment program, any type of, even doctors, law enforcement, pharmacists, we all realize we're dealing with a whole and not just one thing.
Okay, thank you. What studies are you aware of that statistically connect mental health with opioid abuse, and what are the suggestions? Are there early detections or an increase in mental health services?
I don't think we're stumped, but maybe we're all waiting to see who else wants to speak up. The landscape of mental health and substance abuse disorders is difficult, and we're learning new things all the time. The reference to ACEs that you heard, adverse childhood experiences, have a way of measuring where the deck gets stacked against you, but it also can identify areas that you've been resilient and healed and learned. So mental health is not like a badge that says there's something wrong with you. It's something that all of us experience at some time, and sometimes it's harder on some people than others, and we don't know all the reasons. What we do know is that human beings are important and they have value, and that we have to look at not just compassionate care, but look what we've learned about addiction. I mean, we're trying to learn to say the right words so we don't hurt people's feelings. We're trying to not stigmatize people, because stigma is a terrible thing. If for those of you, how many of you were around in the Vietnam War? For those of you that weren't, our soldiers came back and they were evil. People didn't like them. They had a tough time. They took their uniforms off. They were not proud of being an American soldier. And that world has changed. Well, people suffering from substance use disorders go through the same thing. So regardless of, we have great capacity with mental health and addiction treatment in America. As a matter of fact, the track record says that we can deal with issues like that better than medical community can deal with things like high blood pressure, diabetes, and things of that nature. There's a tremendous success rate when we apply ourselves. I think one of the key points that I like to make is the fact that we should not let addiction and the disease of addiction create the kind of stigma or the kind of emptiness around people's lives that then contributes to mental health disorders. That's a bigger problem, because everybody deals with mental health challenges, and some need help at different varying levels. But if the problem of dealing with any illness or disease like addiction makes it harder to deal with it, well, then all of a sudden everybody's talking about how much addiction and mental health have in common. I think sometimes finding our own compassion, our own caring, can at least help people stay on a level playing field so they can deal with these problems as they need to. And I think our people working in treatment have tremendous sympathy for that, tremendous compassion for knowing that when you come in to deal with addiction, you can't blame it on mental health, but it certainly has an impact. Just like addiction can have, or substance use disorders can have an impact on whether somebody tells you the truth or not, or whether they acknowledge the fact that you really care or love them, because their addiction has become more powerful than the people that love them.
I guess I'll just go ahead and respond that when people come into our facility, into our jail, we both have to get them treated for their mental health, as well as drug addiction, physical ailments as well. After they are with us and off a substance, and we can start them into the mental health field, and they can get some medication going, they are clearly a different person than when they entered our doors. Like you said, it's just the compassion that you have to give somebody and allow them to, come around. But
okay, and Mandy, this one may be directed at you, but there may be others that can answer this as well. So we have the YWCA for women. What is there available for men?
In our community, CFR is also available for substance use disorder treatment. I don't care if you want to talk. Yeah.
I think I can answer that a little bit. Yes, so for men in our community, we do offer a residential adult treatment for for men coming in. And as far as our local community, I don't know, other than CFR, that there is anything as far as for guys. But as women, we have our female residential facility as well at CFR, adolescent residential. And then the YWCA offers a unique program for women and children, which is a great benefit for our community. So yeah, there's some options that we have that are really beneficial for the people that we see here locally to treat not only substance use but mental health as well, because there is a direct correlation between the two. And we see a really good success rate when we do treat both of those things. But it's being able to get them in there and really assess where things are at for the person, because substance use can change a person in all different areas. And so getting them, off of substances and getting them assessed and evaluated, we just offer a lot of really good services in our local community that can help with substance use. So we're pretty fortunate.
Okay, just so we have the feed. So Beacon to Hope was what was mentioned. That's more of a religious-based facility that is available for men. But thank you for adding that in. Any other responses?
I will add, around the state, we find that there's both public and private facilities, and the faith-based community has been really great with recovery and substance abuse. I can't impress more that if you're facing with trying to help someone find resources, try everything. You never know, because faith is not scary, private's not scary. Money can be scary, because finding a way to pay for stuff. But yeah, try everything, and keep in mind that every faith community leader is trained with it. But quite frankly, even a dentist, a pharmacist, they could probably help you find resources if you have concerns for somebody. dealing with addiction.
Thank you. So what are the stats on opioid use in the elderly? And then with, kind of as a follow-up, with the doctor prescriptions, big pharma, lobbyists, do you feel we will truly remedy this issue?
I'll answer in that I do believe we can. I think that it goes, if we address the stigma, if we address the perception of risk and start seeing prescription drug use and opioid use, and we start seeing it as a community as a bad thing and start treating it and start knowing it's there and stop stigmatizing people that struggle with it. I mean, there are doctors who get addicted to prescription medications. There are people who are in poverty that get addicted to prescription medications. It doesn't matter where you are. It can be anybody or anything. And so I think if we can address some of those things as a community, we can absolutely 100% start affecting this epidemic. I don't know that we can all out stop big pharma and those kinds of things, but I know that we can make a difference in our community and in the state and in the country by coming together and addressing these things as we see them.
In January, Psychiatric Times, I think it was, came out. They did a big study with the elderly, and there have been some other studies out there, but at that point they found 35% of elderly people over 50 using prescribed opioid medications for pain reported misuse in the last 30 days. That means 1/3 of the elderly that were using it for pain reported misuse. They were using more than they were prescribed. So it's obviously a problem. But we don't know the severity of elderly opioid use. We don't know really well where are they going to go if they can't get opioids anymore. But we also do know that when they have a relationship with a doctor, and we've looked at this in rural communities, and it is tough. It's probably an evolving challenge. That the doctors are hesitant to take them off the opioid medications. So elderly have an easier time of going in and getting them renewed because, you know, in a way it's like the unspoken risk. If we take you off and you go through the pain of withdrawal, what are we going to do? What are we creating as a problem? So I think you're going to hear, as we look at this epidemic, the interesting thing here is you have wonderful self-reporting. Though opioids are used more by people that are younger in addictive ways, 35 and under, very few report overuse. They think they're using the right amount. So I think we have an advantage with elderly as they're a more intelligent consumer, but we have another problem is that opioids don't discriminate when it comes to addiction. And if you were looking for a way to help with pain, you traded a short-term benefit for a long-term addiction, and it'd be the opioid addiction that's driving you to use more opioids as you get older than the benefit you're getting for pain. It's a very complicated landscape. So we have, you know, based on this study, 35% of people over 50 that have opioids for chronic pain showing signs of addiction.
I think the other part of it is with elderly. Oftentimes they try to stretch it out. They also have to balance the side effects of, you know, like constipation. But the other thing is, if they try to stretch out, it starts limiting their daily activities. That's not a good thing either. If they can't do dress themselves, eat, or go out because they're in chronic pain. Whereas if they're on something to treat that, they're able to function like they normally would. So it's kind of a balancing act when it comes to people over 60. Often, the other thing is they metabolize things a little differently at an older age. So a dose for someone younger might be excessively high for someone much older.
To answer on the prescriber side, I think it is something that can be addressed as well. You know, the dental profession back in '98, I think, was roughly 16% of opioids. That's including all of the dental specialties. In 2012, I believe it was under 5% of the opioids being addressed, and that number has continued to drop. So you will see some, you know, prescribers or some areas that are decreasing numbers. I believe dentistry is now somewhere under 3% or right around 3%, and it was 16 back in 1998.
Okay, thank you. All right, so another question we have, how do you think we could benefit as a community by reaching out and allowing recovering addicts to give their testimonies as a form of prevention?
Well, I think group therapy seems to be a proven method. So if it's working for in groups, facilities are using it. So if we have the opportunity, I don't see anything but benefit from it.
I think that it'd raise awareness. It'd make people open their eyes a little bit more, maybe stand up and pay a little more attention as to why people became addicted.
Yeah, I think it would be good too, just on the aspect of helping maybe the hopeless feeling of somebody that listens to it. You know, somebody that's been down the road and is doing better with their problems, giving hope to somebody that's still struggling that it can be done. So
I don't think that a person has to reach too far to say that they at some point have been directly or indirectly affected by substance use. You know, it just happens to everybody. And we see a lot of success with community resources as far as 12-step meetings, group therapy, treatment center therapy. You know, I can speak for, you know, CFR. I know that we have a lot of people from the community, the recovery community, that come in and they hold meetings for our clients that are in residential treatment, you know, and they come in and they share their experience, their strength, and their hope of how they've changed and turned their life around and are in recovery. And so I think that that's huge when one person can identify with another person and feel comfortable talking about that. I think that when we don't talk about those things, it becomes a bigger issue. You know, if we can just put it out there, people are comfortable with that, and we've seen a really good response from that. And so I think it can be beneficial. It is beneficial. It's showing that it's beneficial in our community.
There are a lot of stats that are sort of scary. I remember looking at 2008 opioid stats nationally, and also looking at, so I think in 2008 we figured out that 14,000 19-year-old and younger kids died from some form of drug overdose related to opioids or heroin in America. And we also recognize that same year, 1,860 some, I think it was, died from gunshot wounds. So we're starting to recognize that some of these risks, you know, I'm not saying guns are safe for kids to handle, but opioids are tremendously dangerous. I mean, how many of you know or have used anyone that's had opioids? I mean, just about everybody. It's just an amazing thing. Now, how many of you would have a family event or go through life just not because you're a public safety officer, but carry a loaded gun around with you? But yet we have opioids everywhere. And they're more deadly than guns in America. So if this doesn't raise your hackles, I mean, if you're for gun control, or you have some problem with gun ownership, you think gun violence should be reduced, well, you better look at opioids harshly and get just as much of your dander up for that, because that is deadly. kills more people. As a matter of fact, drug overdoses in America for the first time are killing more people than traffic accidents. So now using prescription medications are more dangerous than driving a car. And I'm willing to bet that most of us don't go to bed at night thinking, well, I better be careful when I take that next pill from the doctor. We get in our car and we're sort of careful. We handle firearms, we're sort of careful. But boy, we just have meds flying everywhere. We need to start changing that a little bit.
Okay, we have a long one here. Endocarditis, an infection of the heart valves, is often directly caused by infection, is often directly caused by injection drug use. Currently, the rate of endocarditis is at an all-time high and is projected to increase. One large issue is that the patients are treated in the hospital for the infection, but the underlying issue of addiction is not adequately addressed. This is because of insufficient insurance coverage and insufficient resources to treat the addiction and mental health issues at the root of the problem. How can we change the system to enable optimization of treating patients during these hospitalizations for infection? And how can we obtain the resources to help these patients successfully transition to the community? Good luck.
That's $1 million answer. I mean, you got that one, you solve a lot of problems. You know, I think that that's a very astute question from somebody that knows something about a disease and understands that there are underlying factors that contribute to how these diseases manifest. In the same way, we know that if you use certain drugs, your certain health factors are going to be diminished, and some of them may manifest in some serious problems. But we also know that excessive video game use or excessive social media use results in less sleep, a higher BMI, more antisocial behavior, and other health. So, you know, we live in an entire culture with risks and threats, and it's a beautiful world we live in. But we make a lot of really terrible choices. Now, addiction is not necessarily a choice, but a lot of the other things that we do to contribute to our ill health, whether it's our diet or our activities and other things we pay attention to, maybe are. You know, doctors today, when I go in, they're not looking at me and saying, here, take a pill. They're going, well, how are you eating well? You need to exercise more, lose some weight. I mean, the whole medical practice has changed. And my wife is on me, hey, why are you eating that donut? You know, I'm like, the world seems like it conspires against all the fun. But when I was a kid, my kids came home from school to get me to quit smoking because they listened to some speaker that said smoking was bad. Well, it worked. It took a long time, but it worked. So there's this sense of, the question says, man, you really get it, that there are a lot of interrelated things and that you can ask a question that makes perfect sense and nobody really knows the answer to, like why is the world going this way or whatever. But it also means that looking at how these things relate are an important thing to talk about, an important thing to share, and maybe if there's enough voices, enough energy, money, and resources go towards resolving some of these problems. Because if we don't hear the questions, we don't even know they exist. And quite frankly, if a doctor's trying to, you know, doctors have a lot of work to do. You come in the emergency room and they do something, they're trying to get you healthy enough to walk out the door. They're not necessarily trying to look at underlying issues. But it's certainly a valid quest for the individual to not only undertake, but maybe go back to the general practitioner and say, hey, maybe I need some help with something else.
I think the base of that is we live in a society that is often reactive and would need to change its mindset to be more of a preventive society, and throughout all of medicine, but also with lifestyle choices, as you mentioned. I mean, it would come down to diet, exercise, and you know, all of that across would have to become more of a preventive society to make those changes.
Thank you. So next question is there a risk to people who handle large amounts of money, such as a bank teller, who may come into contact with money used in drug deals of fentanyl?
I guess when you're talking about a substance where as small as a grain of salt can kill you, and something the size of a grain of salt could be attached to money. So there is the possibility. Money is used every day in drug transactions. Many times they're in the same container. We see it all the time. So I would think that there is. So it may be a benefit to have a way to combat that. So. We had a police officer go down, and the only thing he had was contact with a subject and not close personal contact. And after handling the subject's ID, he wiped the side of his nose and inhaled some substance. It was small enough, there's no way he could have seen it. And if we didn't have a way to combat it, he wouldn't be with us today. So it's going to have to be, when it's in our society, we're going to have a way to combat it. And until they get the substance stabilized, it's going to be difficult for us to contain. I mean, we carry the substance with us in our cars, and it has to be removed from the cars every night. Can't stay below a certain temperature. It can't reach a certain temperature. The car will easily cross 100 degrees in Iowa during the summer, and it's going to be way below freezing. And the substance is just too unstable. Hopefully we can get it more stabilized, but until then, at least we'll have it with us. And then with the case with our police officer, they had to get 2 doses before he was able to respond. And I think the first week that we had it with us, I think we had 1 police officer, 1 subject on the street, and 1 subject coming into the jail that had to get several doses before they were able to respond.
The doctor raises a great point, is we have to make sure that we don't become paranoid. We have naloxone. It is a risk, and what we've also learned, there are much greater efforts to take fentanyl off the illegal market, and at this point, it presents huge risks. But on the other hand, I'm looking at some of the stats for your odds of dying if you live a regular life. Heart disease is 1 in 6, cancer 1 in 7, chronic lower respiratory disease 1 in 27, suicide 1 in 88, opioid overdose 1 in 96, higher than car crashes, falls, gun assaults, motorcycling, drowning, fire, smoke. We don't want to be paranoid, but the opioids and the fentanyls and the opioid derivatives are going up that list, getting higher and higher as the cause of death of more and more Americans. So we have to find that balance. We don't want you just running scared from everything. But there's also good reason to be cautious, and for our governments and people that take fentanyls off the market, because these things, the fentanyl that's reaching the drug business are developed illegally overseas, across borders, so we have drug interdiction problems, we have trafficking problems. Police officers are dealing with this every single day, and so for them, that risk of accidental exposure is probably a lot higher than any citizen in the room. But no reason not to pay it a mind. But it's their business to be at the point where these things can be stopped. And that also means they're probably going to have a much higher probability of encountering those things.
Yep. I agree. I don't mean to cause some extreme fear for people here that do handle money, but I guess I just responded to the question, is there a possibility? Yes. But again, I agree.
All right, so while we're kind of on that topic, so talking about the illicit drugs that are available, how easy is it to get off of the street? So this is going to probably pertain to our law officers, but I guess what's the difficulty level of getting some of those, whether that's prescription or illicits, off the streets?
I guess two-part. I'll answer it both ways. For us to get it off the street, it's kind of hit and miss. Our biggest issue with opioids, I think, is the prescription pills. The fentanyl, the heroin, stuff like that, we just haven't seen a whole lot of yet. We have a few cases, but it's a much bigger problem in eastern Iowa, so we just don't deal with it as much here. I guess the second part of the question maybe is the availability to get it. Again, I think the prescription part of it, it's pretty easy to get. The street part of it, the heroin, the fentanyl, I would say it's pretty difficult right now. I mean, I'm sure you could do it if you hung out with the right people, but it's not a big issue availability wise right now, like the meth and cocaine and stuff like that is. So
the subjects that we are getting in on the jail floor never make it, they always make it known it's never a problem for them to get it. They had always advised us that when they get released, they can have it in 5 or 10 minutes. So our drug officers, kind of a common thread they use is sometimes they feel like they're fighting a losing battle. They collect a certain amount, and the next day there's more there, and they collect that, and the next day there's more. So it kind of comes down to human nature, where there's a will, there's a way. And as I said in his presentation, it's coming in the mail, it's coming in by vehicle. With the opioids, if they don't bring it into the drug take back, it's available in grandmother's medicine cabinet. So, but we just have to keep fighting. We keep pursuing it. We keep going after it. We keep taking them down, and we keep taking them to jail, or we send them to prison. There are going to be more, and we'll go after that too. So we too present a never-ending battle.
Thank you. So our next question. When Sudafed was regulated, more methamphetamine was brought in from Mexico. Do we predict this with increased regulation of opioid prescribing?
yeah, I would absolutely say that'll be the case. I mean, I think you're already starting to see it with some of the fentanyl and stuff in the heroin mixed into meth and all that stuff. I think the problem is transitioning to heroin and fentanyl, those type of opioids, because of the prescription pill problem that we have. It's just transitioning from the problems we have with the pills into something that isn't as regulated and is going to be more accessible. So I think that's a pretty good correlation.
Yeah, definitely. Fentanyl's not even our most potent narcotic out there right now. I mean, they're continuously developing something more all the time. And well, when we started fighting methamphetamine, it just came across our borders. It came from another source. We fought it one way, now we'll have to fight it another. And we'll have to fight this epidemic just the same way.
As long as people want the drugs, they'll find them. And there'll be unscrupulous people that create them. You know, drug cartels that really provide a large percentage of the drugs that enter America. or even created in America. They're not dummies. They're not some scrub living on the street trying to eke out a living. These are business people. And I heard a quote, and I don't know what the source is now, I'd have to look it up, where they were talking to a cartel member in Mexico, and he said they're basically trying to restructure their business to take advantage of the opioid epidemic. As less opioids are available in America, they want to be able to provide the drugs to the people that want them. That's their business model, which is why we put so much effort into prevention. Because if the demand is not there, they'll move on to something else. But right now, that is a demand they sense, and they went from fentanyl to carfentanil, which is that grain of sand thing is now something 10,000 times stronger. This is because it's just a matter of economics of scale. The more powerful they can make it, you know, when they ship heroin to the United States or meth, it's really pure. It's just that people cut the heroin, they dilute it to increase the volume so they can sell more. As a matter of fact, when pure heroin used to get on the streets, it would kill people because they couldn't figure out how to dose it. So the drug dealers step on it, they called it, they cut it to fill it with stuff so they can sell it so people don't die and they can make more money. So there's a huge science to all of this. That people that are astute, the evil business people, know how to manage. So as long as people want these drugs, somebody will create them and they'll find a way here.
To talk about the cross addiction, when people stop using or don't have access to the prescription drugs and then move towards an illicit drug from the streets, say hydrocodone to heroin, which might be a jump, but what we have to do as a society is take away that stigma and have the doctors, instead of just cutting off the medications and saying, I'm not prescribing this anymore, having a discussion about whether or not this person is having trouble with the medication, taking it not like they're supposed to be taking it, and then be able to offer them options like medicated assisted treatment, like counseling, to be able to not seek drugs in another way. So then if we can end the drugs coming into America that way by having a conversation up front and reducing that stigma, training our physicians. I mean, every time you go to the doctor, they screen you for depression. Why aren't we talking about these other things when it comes to prescription drug use?
To piggyback on that, I think the hardest thing is pain is subjective, whereas diabetes, high blood pressure, high cholesterol, there's a number attached to it, whereas pain, you know, how do you prove someone has pain? They can easily go to the doctor and my back hurts. Try this, naproxen, ibuprofen. You know, it'd be pretty easy for them to go back and say, well, it didn't help. I need something a little stronger. I think that's the difficulty of it.
Okay. So another question we have. Do you believe society should destigmatize addictions by not criminalizing the user? And should their records be expunged so former addicts can move forward to move on to positive lives?
It's kind of a minefield there of a question. But I don't agree with legalizing substances. I don't agree with clearing somebody's record. They can still move ahead in a positive way, even with their records tainted. But it's actions of their own lives that, unfortunate as they are, is part of their lives now. And anytime somebody commits an offense and they have a history, the press finds it, and it's their job to find it. And they go back and they find it. Well, if we cleared their record, if the system clears their record and find out that they've had a history of substance abuse or a history of anything, it's going to be brought out. So society wants to change that and wants to make it so that there's not something that's tainting their record and putting a cloud over them. But the very moment something goes wrong, they also don't want that either. But personally, I'm not in favor of legalizing substances and trying to make the pathway easier for somebody. I think the pathway is through education, through meetings such as this, and just making people aware of what's in their life or what's around them so they can handle it. Sweeping it under the rug or not facing it is not a way of dealing with it.
Okay.
Yeah, I would agree with what Rod said. There still has to be some accountability. Even if it benefits that one person, it's not going to benefit anyone else. I mean, you're just going to see the next person that's using or gets charged with something, they're going to look that there was no consequence for that other person, so they're just going to continue what they're doing. Rod summed it up pretty well. There has to be accountability.
You know, I do a TV show, and because of that, I get to meet a lot of people that have lost loved ones, been in jail, suffered bad things. I found something curious in the hearts of people that have overcome addiction, that have been in prison and everything else. Once they've been able to overcome the addiction, very rarely do they feel as if they need to have their record expunged. They felt like they paid their price, but they're happier to be done with the substance abuse disorder than they are worried about the fact that they had spent time in jail or prison. Yes, it might impede them getting a job, but they know that it impedes them much less than the use of those substances or the addiction did. So sometimes I wonder if that preoccupation, because we really didn't hear a lot about expunging drug records until there was a marijuana legalization movement. And that was I don't know. I don't want to get into that now. This is an opioid discussion. But when we take a look at this from the point of view of the addict, there are issues that exacerbate people's actions to the point where they're regrettable, and they might end up in prison or jail or arrested. And substance abuse and mental health issues have something to do with that. And we know we want to improve that treatment. But from the people I've talked to that have been down those processes, whether it's been mental health issues or substance abuse disorders, when they have got better control of those problems and they feel healthier and better because of what they've been through, they're not that preoccupied with all that baggage from the past as they are building a better future. So I don't know that that's as big an issue. The stigma is an issue. I mean, we need to have employers that say, all right, you were in prison, but that doesn't condemn you to being a bad human being. How's your life going? You know, in this world, we're learning. I don't care who you are. King with that guy with the hospital. You know, you can try and expunge a record, but like you said, you're not going to hide anything anymore in a fully digitized world. So we might as well figure out how to live in a transparent world and get the job done, which is caring and healing people.
Some of the best people I know have prison records. And so I think that it's us working as a society to remove the stigma from substance use disorder, from addiction and those kinds of things, so that people aren't so scared to employ someone who's in recovery. So you're not worried about so much of those issues, because I can tell you that some of my best employees are in recovery, and I wouldn't change that for anything, because they have such a moral code that you don't see in general. So I think I wish I could put that on a billboard, hire these guys. And so as an employer, as an advocate for people with addiction and in recovery, I try to spread that message as much as possible to reduce the stigma. So I think we could work as a society to remove some of the barriers for people, such as certain offenses, make it so you can't get housing and things like that. We could work to maybe tweak some of the laws to make it easier when people do better in their lives. But I don't think that just saying all drugs are legal and we're just going to forgive everything would do any good for our society.
As a pharmacist that has in the presence of controlled drugs, opioids, to have a potential pharmacist or technician and having their record cleared if they were any type of abuse or addiction, I don't think would be a good thing, just because it'd be pretty easy to fall back on the same habits. You know, when you're in the presence of all the different controlled drugs and opioids, it'd be pretty easy to relapse because of availability. And in those circumstances, probably have to have extra supervision or a different type of setting that not in the presence of potential relapse.
I guess I would also add to what Mandy talked about. Excuse me. I have worked with several individuals that would tell you that it was those consequences, the natural consequences of their substance use, that have directly changed their life. You know, having their children removed because of substance use, they would tell you that that was the reason that they would even consider recovery, because of those consequences. And so, you know, they're grateful. And I've also watched those people make change because of having walked through that process. You know, and working directly with the Department of Human Services and making change in that area as well. I would agree that, you know, I think that some of those things that they have to suffer the consequences for could be the very thing that's saving their life.
There's one role in law enforcement, I guess, that you don't really see or don't think about, is the fact that we do have individuals that come back and talk to us after they've been incarcerated in prison or after they've gone through recovery, and it's part of their life now. It's how they communicate and how they talk to us, and you know, they talk about their substance abuse. They don't hide it. One thing it is, I feel regretful after you do charge somebody, that it becomes difficult for them to get into treatment, or it becomes difficult for them to get housing because it becomes a landslide. It's still, again, you know, asking a law enforcement officer if they want to expunge records is kind of like I say, it's a minefield. Your answer is usually going to be no. But I do feel that regretful when we charge somebody and then they can't get housing and then they become subject to living on the street. They don't have the resources. And if there was leniency there, it would help. Because once they have recovered, and there is a time frame, to still lock them out of benefits is I don't know, sometimes I refer to it as being a little barbaric, because we're forcing them out on the street.
All right, thank you. Our next question, we've heard the term discussed a little bit throughout the panel, but as far as medication assisted treatment, or MAT. So where is the nearest medication assisted treatment center is the question.
Well, I can answer that. We have one located right here in Fort Dodge out at Community and Family Resources. It's been a huge asset to our community. Making it accessible to our community has been a big deal. And so, yeah, it's available at CFR.
The Webster County Jail utilizes community health and community family services a lot. We wouldn't know what to do without them. So it is a benefit.
Thank you. Next question is, we see painkiller ads on TV many times throughout a day. Can we stop those ads, and do we think that that would help the problem?
I think in general, educating people is a huge thing. I can't tell you how many people have sat in front of me during an evaluation telling me that they just didn't know when they were prescribed pain medicine what the effects were going to be like when they were taken off that pain medication. They just were very uneducated. And so the prevention is huge. Just getting the information out to people is a big deal. Because if you've ever seen anybody go through withdrawal from opiate addiction, it is a very terrible thing to have to watch. And so, and I don't know anybody that would like sign up for that, truth be told. So I think, you know, just getting people the information that they need to know, educating them on all of those things, and that's the responsibility of a lot of different places. You know, the individuals themselves, you know, teaching them how to advocate for themselves when it comes to prescription medication or any other kind of substance.
I think as a parent, being informed more how the medications that are given to your children affect them would possibly change the course of what you would choose for treatment for your child too. In my case, had I known that my son being prescribed that many times hydrocodone, how it would affect him, we probably would have been seeking out other options much sooner for treating his pain.
On that question, I just, it refers to the advertisement, and I just grew up in an era where they didn't bring the advertisement to the patient. The drug information or advertisement was brought to the doctors and the pharmacy, and they decided what you were going to get. You don't watch it on TV and decide what medicine I need, and because that's just what we see when we take people in that have drug addiction problems from our jail. They go to the doctor and they go in and they ask for a specific drug. Many times they know what to say and how to ask for it. But, you know, I'm not advised of all the information they've had before in their past. But that's just that kind of advertisement that comes right to them. It comes to all of us. We watch it every day on TV. And no, I'm not a fan of that at all, because that information is not, I don't see it as being informational for us as adults or as parents. It's strictly, it shows the good life that they can have if they have access to this drug. And it's just, I don't see it as a benefit to our society at all. I wish there was some kind of a way to stop it, but.
There are two countries in the world that allow the advertising of pharmaceutical medications on television, the United States and New Zealand. We prescribe more drugs per capita by far than any other country in the world. Pharmaceutical companies look at us as consumers, like Coca-Cola, Pepsi, or the tobacco companies look at us as consumers. You know, I heard a pharmaceutical rep give a talk and said, you know, we knew in the 60s and 70s with the number of people that experimented with illegal drugs, that if we could come up with a pipeline of legal drugs promising all sorts of different things, we would be, I mean, and if you look at the number of drugs available today to the amount of them that were available then, it's an amazing thing. Now, I'm great for double-blind studies and therapeutical studies and finding more medicines to cure more diseases and more research. But somewhere, we need to entrust the FDA, doctors, and the medical community to make these decisions. The fact that these are commercials on TV makes no sense to me. In other countries, they laugh. They go, why did they send people to medical school for all those years? Why do they train pharmacists? And yet then they put commercials on TV and have people in there demanding certain drugs. And this is a problem because just the same way that pain is one of those subjective values that led to major problem. I mean, if I'm telling somebody, if I'm an addict, I have a lot of pain. I'll tell you what, I'd make up all the pains I needed to get the drug I wanted. Best way to get it. But the fact is that we all seek out shortcuts in life. And sometimes we get taken advantage of. But again, now, is it our fault that we listened to these ads and thought that we could have better sex, better sleep, better breathing, better this? No, but we need to realize that they're not telling us the truth. That for most of these studies, only a small percentage of people get a benefit. All those little fine print things in the bottom of the ads, try reading them. If you saw the fine print in big letters and then the benefits in small letters, you'd say, I want nothing to do with this. So we've been consumers. We've been behaviorally modified by ads on TV to be able to pick medications when we have doctors trained to try and help us heal. We're going in thinking we found a solution on television. Well, I tell you what, I don't want to discredit pharmaceutical companies, but there's a lot of infomercials out there, and I would bet you that those pharmaceutical ads are way closer to infomercial than they are a doctor's visit. And now, I have a biased position here. We do research on media and digital literacy with kids and with people, and we know that these ads are designed to influence your behavior. And the fact is they do more harm than good. We don't have a country that's willing to take them off the table, but we can't be the only good country on the face of the earth. And America and New Zealand aren't the only great countries. There's a lot of other ones in this world too. But we happen to be a country that big business has a lot of potential to take advantage of people. So where does that, how do we stop that? Well, let's be America, that's okay. But learn from your prevention organizations, learn from these messages, these town halls, spread this knowledge, and let's stop being stupid consumers. Let's stop believing all the promises we see in the media and trust the people that invest their lives, their education, and their public service to help us make those decisions. Not some advertiser who has only one interest from that ad, money. They don't know you, they don't care about you. When they put that ad out, do they put qualifying conditions in there? No. They don't care. It's like just throw it out there and whoever wants it, they'll figure it out. So, my opinion, totally bad idea to believe those ads. Trust a doctor.
This is kind of not quite related, but a lot of the manufacturers now have to have abuse deterrent, meaning if they try to alter the medication in any way, either makes it inactive or unable to inject. There's some that if in a capsule form, if they try to open up the capsule to modify it, it also has naloxone, which would make the opioid ineffective. So, but those are usually just the brand name medications. For the older medications like morphine, hydrocodone, there really isn't any way of deterring it. Even with the abuse deterrent, it still doesn't prevent diversion. And I think that's the hardest part, is to prevent that. Yeah, there was a form of hydrocodone, just hydrocodone single source, no Tylenol, but as expensive as it was, it never caught on.
And we do just have a couple more questions, so we'll try to get through these. I know we have a few minutes left here. So doctors' offices have made it a practice or mandatory to educate on weight at each appointment. Shouldn't they have the same talk or education about this epidemic? More reading materials in public places, posters, brochures, pamphlets, etc.
I think I answered that already when I said absolutely. I think that that's a discussion that should always be had when doctors are specifically prescribing this medication or see that opioids are on perhaps their patient medication list. And we talk about weight, we talk about mental health and depression. We need to be talking about addiction and substance use disorder as well.
Okay.
There's not just a questionnaire to get into a doctor's office. There's a questionnaire to get into jail. You have to go through and answer the questions. And we ask those specific questions.
All right. Is there education, or is there, or can there be education on this topic in our schools? If so, at what age does it start?
I speak to assemblies of middle school students all the time on these issues, high schools as well. But the schools want us more at middle school, feeling that the younger age is necessary because a lot of their behavior is already molded by the time they get to high school. And the in-services I do with teachers are generally elementary. I want to learn better how to handle these questions in the classroom.
And I know I can speak as being in the prevention department for Community and Family Resources. We have curriculums, materials for all ages. We can do anything from kindergarten to high school to college students. So we do have materials that can be done and adapted at any level. So it can be done anywhere. It's just there's not enough people in prevention compared to the amounts of schools that are requesting. So that is always the struggle, is trying to balance that between getting into the younger youth, but also being able to serve kind of the lifespan of people that are out there, because it's not just a focus on the youth, but a focus on everybody in the community as well.
Can I ask a question of a panel member? Do we have time for that?
Yeah, we have a few minutes.
Denise, in my opinion, you're very qualified to give us things on this topic about things we'll never know. In being here for this time listening to us, what are some of the things that have gone through your head and some of the things you would share with the people here?
I would share that you definitely need to be asking more questions with your children, what they know, what they hear in school. I would also be asking your medical provider more questions about what's being prescribed or what course of treatment you can take. I would definitely be finding out what they're learning in school, how much education they've been given on it, and just what their peers are talking about. That's huge, knowing what their peers are talking about or doing.
Okay. Well, we don't have any more questions at this time. So is there any final questions that anybody in the audience would like to ask? And if, oh, yep.
Just one thing, when you were talking about this. To go to this school and talk. There's a teacher at the high school that he has me bring guys from the mission all the time to give their testimonies in his class. And Bryce White, when he was here, giving his testimony. I mean, testimonies have a great influence. The stories stick in their heads and in their hearts.
Thank you. And so just one final time, I want to thank everybody for attending the event tonight. We appreciated all the questions, and we also thank all of our panel members for their answers and their commitment to this tonight. So thank you.